The following content is provided under a Creative Commons license. Your support will help MIT OpenCourseware continue to offer high-quality educational resources for free. To make a donation or view additional materials from hundreds of MIT courses, visit MIT OpenCourseware at ocw.mit.edu.
This is very strange. So let me tell you guys where I am first, so you get a notion for how strange this is. I'm in an airport lounge in Amsterdam. So if you can move the next slide left.
Yes.
We're here with 2,800 people at the International Forum. There's people from every continent. And we estimate there's about 75 countries here. So it's been a pretty exciting 3 days. And there's been some pretty clear messages in relation to the need to continue to work on quality improvement and safety, and the long road that we still have ahead. If you click the slide, there should be something coming up that looks white in the left-hand corner. Does that happen?
Yes.
Okay, so that's an illustration of some of the messages that I want you to take away with you. And again, as I understand this group, it's a pretty mixed bag. So it's a urinal, okay? So when we think about safety, we don't think about urinals. We think when we're talking about safety, we're talking about harm to patients that's unintended. People that work in healthcare want to do a good job. They come in to work with the best of intentions, but they work in systems that are not necessarily designed for reliability. The urinals in Amsterdam. In most places that are public, they had a problem. The problem started in the airport here in Schiphol, where men are really bad at aiming. So that's just part of our natural condition. Okay, that's just the way we are. We're imperfect. They looked at the process of what happens cognitively when people go to the urinal, when males go to the urinal. And they came up with a solution that's pretty clever, that takes into account the cognitive aspects of human nature. And they actually drew a fly in the middle of the urinal, which is the black thing that you can see at the top, sort of towards the left of the middle. And they reduced the smells in the public toilet significantly. So every system is perfectly designed to get the results that they get. It was a cognitive solution for a pretty systemic problem. Now, we face that every day in healthcare. We work with highly complex situations, highly complex patients in highly complex environments, and solutions don't necessarily have to be rocket science. Cognitive science is a huge part of it. If you can go to the next slide.
Yes.
So just a bit of context, because I'm not sure what the backgrounds are or how deep you are into quality. These are the 6 domains of quality. And if I can point you in the direction of any report, I would suggest that you read a report called Crossing the Quality Chasm, which describes the nature of and the state of healthcare in terms of quality. But we're looking for healthcare to be safe, timely, effective, efficient, equitable, and patient-centered. And we created a list of needless things, so things that we do not need. Needless death, needless harm, and needless suffering. Delayed, wasted, infliction of health. And I put at the bottom there a phrase related to the last slide in relation. James Reason is a cognitive scientist from the University of Manchester, well known for his work on safety, and he said something here that I think is another takeaway. We cannot change the human condition, but we can change the conditions under which humans work. And again, I'm not talking about wealthy hospitals, wealthy facilities, expensive equipment. I'm talking about basic design rules here to improve reliability of care. If you go to the next slide.
Yes.
So we're okay. So I put this at the bottom, the Global Trigger Tool study. That's a tool that we designed as the Institute for Healthcare Improvement, which, by the way, is not based in London. We're about 3 kilometers from where you are right now. We're in Cambridge. And we're a small family that has a big mission, which is to improve health and healthcare worldwide. I happen to be based in Northern Ireland, but I work off the Boston office. This is a study that was published yesterday, actually, in Health Affairs, that talks about that 1 in 3 patients that are admitted into hospital suffer some kind of adverse event. So Health Affairs is the reference, and I would invite you to read that if there's anything that's appealing in relation to the next 15 or 20 minutes with me. So the next slide. If you click twice until the blue graph comes up, do you have it up? Yeah, so this is just a picture that probably many or all of you have seen, where healthcare is actually compared to other industries. So at the extreme right of that, you have the high reliability industries. I'm thankful that the scheduled airlines are there, because I'm about to board a plane in about an hour and a half, and the slide relates to encounters fatalities per encounters, and then on the left-hand side you look at the total lives lost per year, and healthcare compares very unfavorably with high reliability organizations, but highly favorably with highly risky things like mountain climbing and bungee jumping. So just a bit of perspective. The next slide talks about Latin America. So this is the context in which the Latin American hospitals have been evaluated, and this is on the right-hand side. You can see the rate of harm. So you talk about a rate of harm of around 10%, which is a worldwide figure. The figure I quoted before of 33% relates to adverse events using a global trigger tool, which is a different method that they use here. But we are talking at least about 1 in 10 people get harmed when they go into hospital. If we see the next slide, and we'll go through this very quickly. The next few slides are just contextual. So I try to give you a flavor for what, for example, in Africa, they're thinking and planning and actually doing. And this is all very high level. So at the Institute, we try to be pragmatic. We want to ensure that we design solutions which are embedded in clear aims that set direction and that actually achieve breakthrough results for patients and to increase the joy of staff. So this is general direction of travel for Africa in relation to patient safety, policies, focus on surgery, infections, etc., etc. So if we go to the next slide, I'm gonna focus a bit on state surgery. So just the world around healthcare infection is absolutely massive around the world. So you have at any point in time 1.4 million people with a healthcare associated infection. And the figure is 5 to 10%. The risk in developing countries increases twofold or up to 20 times. It's up to 20 times higher with patients and patients undergoing surgery are the most affected. Next slide. These are some of the causes that you know and you're familiar with. So weak delivery systems, poor infrastructure, particularly in the public sector, weak management capacity, under-equipped facilities, overcrowding, and so on. The presentation today is geared towards trying to give you a flavor for what could be done despite the conditions, regardless of the environment and the country in the world. What are some of the basic things that could be done to improve the state of safety globally? Next slide. And we couldn't, of course, ignore the problem of workforce and HR. And this is just a worldwide picture of the ratio of population per physician. And you can see the stark differences, and Africa particularly is well under the average that you can see, for example, in North America, in South America, which is still pretty decent. Next slide. So let me give you 2 examples of things in relation to safety. So we're talking about patient safety, and the next 2 examples are pretty hospital focused, but the principles, I think, could be transferred to any setting. And let me tell you this before I forget. Safety is, of course, embedded under every other aim. So if we think of safety in resource-poor settings or in low and middle-income countries, we need to think about things like equity and access and so on, because those are primary drivers of anything that we can think in relation to safety. The safety that I'm referring to here refers to the process of taking care of people, of human beings who we want to make a difference for. So let me take you through these 2 things that are pretty simple, and which I'm sure you know well, at least one of them. So next slide. And then the next slide again. So surgery was until recently not necessarily perceived as a public health issue because it's so highly specialized and it happens in such specialized physical areas that it wasn't seen. When we look at the data behind surgery, there's about 234 million operations globally every year. And there's about between 0.4 and 0.8% of those people die, and there's a higher number of complications. What does that mean in terms of numbers? At least 1 million deaths and at least 7 million people that are disabled as a consequence of complications that happen after surgery every year. So these are the gifts that we give patients. So the privilege of working in healthcare, the patients put their lives in our hands, and these are some of the gifts we give them. We try to give them dignity, we try to give them high quality, but these are some of the unintended gifts that we give them. So what are some of the solutions? Next slide. This is the article that was published after the big study in the New England Journal. So this talks about the credibility of the study in relation to the reduction in morbidity and mortality globally. So this guy looked at, next slide, 8 countries throughout the world, and what did they come up with? And again, I'm getting into a plane. I thought this would have been pretty relevant. In the airline industry, part of the reason why they're highly reliable is because they use checklists for every single thing that they do. A plane does not take off unless every member of every part of the team goes through their checklist before the flight takes off. And that means pilots, that means air hostesses or air hosts, that means the whole team. This is a pretty simple tool that has been in existence for years, but which in healthcare we just have not caught on with this kind of tool to aid recognition. So this is a pretty straightforward tool. On the left-hand side, you have what needs to happen before anesthesia. In the middle, you have what needs to happen before skin incision, and on the right-hand side, you have what needs to happen right before the patient leaves the operating room. So think intuitively here. What needs to happen before? You need to know the patient's name. You need to know whether you operated the right side and so on. In the middle, what needs to happen? You need to make sure that antibiotics are given at the right time. You need to understand whether you have everything that you need to perform the operation. And on the right-hand side, you need to ensure, for example, that you haven't left anything inside the patient. So this is pretty basic stuff, not rocket science. They look at 8 sites throughout the world. That's the next slide. So you can see there's high income, middle income, and low income, and they looked at a large number of patients. Next slide. Are we at number 17?
Yes. Yes.
Okay. So what happened with the use of the checklist? It was found to reduce complications and death by more than a third. Next slide. These are some of the numbers here. They looked at almost 4,000 cases before and after using the checklist, and you can see the rates of death, almost half, the rate of complications down by almost 40%, and the rate of SSI, means surgical site infections, down by 40%. And people that were coming back because they needed something done because the operation hadn't gone well, which is that last category there, was down by about 35%. To next slide. So was it dependent on high income or low income? And you can see there that the differences were pretty marked in both contexts. Next slide. So what did the checklist address? The correct patient and the correct operation, and you can see some numbers and some statistics there around how often this happens, surprisingly and shockingly. Next slide.
Yes.
It looks at problems. It deals with problems of anesthesia and resuscitation. And again, there's a study cited there around the extent of the problem. Next slide. It minimizes the risk of infection, and there's pretty straightforward things that you need to do. For instance, give an antibiotic between 0 and 60 minutes before an incision reduces surgical site infection by 50%. So this is process stuff. Very straightforward process stuff that is almost all of them, it's not dependent on having a fancy piece of equipment or on having a fancy theater. It's dependent on ensuring that you support human nature and cognition to minimize errors and harm. Next slide. Effective teamwork. We could talk about this for hours, but we understand, we know, we're well aware of the fact that there's hierarchies in healthcare, and then there's human behavior, which is highly complex. Next slide. This, for me, is the most interesting one, which talks about the challenges in implementing things, new things into healthcare, into any industry, but particularly healthcare. So they asked the team from the 8 countries a number of questions. So was it easy to use? Well, 80% said it was okay. Did it improve safety? About 80%. Did it take a long time to complete? Some thought that it did. Was communication improved? Yeah, for the most part. What did it help prevent errors in the operating room? So this was the people's belief. The last question asked the members of the team. So these are operating room, operating theater, nurses, surgeons, anesthetists, and so on. If you were having an operation, would you want the checklist to be used? 93% say they would. So despite the fact that some of them were challenged to introduce this thing initially, which is a pretty straightforward tool, they saw the inherent value of it by responding. Almost every single member of every single team around these 8 countries responded that they would definitely want to have the checklist used if they were having an operation. So next slide. The checklist is meant to be customized. So the basic elements are there, but it's meant to be customized depending on specialty, depending on the nature of the theme, and so on. You're meant to deploy it in an incremental fashion, so you start very small with people that are championing initiatives, that have championed initiatives in the past, and so on, and then spread as you can demonstrate results. And I'll show you some of the innovation principles that are used to introduce tools of this nature. It's supported by scientific evidence, and you can read the rest of the points, including the last one, which is about resources. So minimal resources are required to implement this thing. We're not talking about huge investments, we're not talking about huge technology, we're just talking about things that are pretty commonsensical. And what I would ask you to think about is how we could implement checklists in many things in healthcare. What usually happens is that people end up writing protocols and guidelines that are maybe 30 pages long, 20 pages long, and the reality of providing care is that it's much more dynamic than that. So we need to make it easy for people to do the right thing. We need to make it easy for people to do the right thing. Next slide, are we on the map?
Yes.
Okay, so that's just a demonstration. There's over 4,000 hospitals that have adopted the checklist. That doesn't mean that they have adopted it reliably. They have 20 operating rooms, 20 theaters. It doesn't mean that it's everywhere. It means that they have started to use it. So there's over 4,000 hospitals doing that. Let me go to the next slide. This is another concept. So one is checklist. The other one is this concept of bundles. So a bundle of care is simply a cognitive aid. And I've showed you this example here. If you're thinking about central line infections and you want to minimize central line infections, you can think about a pretty complex process that looks at the patient, looks at the setting, and so on. What was done here, and we were part of this effort, was to try to simplify what were the four top things that you needed to do in order to minimize or eliminate central line infections. So use a septic technique, use a certain type of disinfectant for the skin, select your site of insertion, and use checklists. These are 4 things. The condition of a bundle is that it's all or nothing. So if you're doing 3, but you're not doing the last one, you're increasing the risk of infection. If you're doing 2 and you're not doing the last 2, you're increasing the risk of infection. So you're only reliable when you're doing every single one of them. What it does is that it simplifies the mental process of thinking about how to solve a problem. So 4 things packed into a bundle. It's called a bundle of care for central line infections. And at this one, we have one for ventilator-acquired pneumonia, and people have expanded the concept to include many, many things. So you can think about bundles. Let me just show you a result from a good friend in Scotland on the next slide. If you can go to the next slide. Andy Longman's team in an intensive care unit in Scotland have gone about 2.5 years without a central line infection, which is pretty impressive. After the intervention, after the implementation of the intervention, you can see that it took about a year for the intervention to get the reliability. Reliability in this case means 95% of implementation. So in 95% of opportunities it's implemented, and you can see the outcome. So next slide. Let me give you some principles pretty quickly in relation to how we can think about safety and some of the solutions around it, regardless of context, regardless of resources. So next slide. The first one is well known, I'm sure, to most of you, which is this idea that structure plus processes equals outcome. So we've talked about processes primarily. We've talked a bit about structure in relation to the checklist. Structure plus process equals outcome. So we saw in the last two slides, they implemented a process, which is a bundle, and they got a pretty good outcome, which is the elimination of central line infections. Then the second point is reliability. Reliability in healthcare, and I'll say it again, it's 95% in terms of process, a process that takes place in 95% of the opportunities that you have to implement that process. Anything under 80% is absolutely chaotic. If you think about reliability in the airline industry, it's pretty close to 100%. So it's 99.99999 and so on. And hence, there's a reason why planes don't necessarily fall that often, thankfully. And the last one is just a way of thinking that I wanted to expose you to, which some of you may be familiar with. This is what Everett Rogers wrote in The Diffusion of Innovation. And when we're introducing something new, so regardless of how fancy or how simple it is, when we're introducing something new, these are 5 conditions that we can use almost as a checklist to understand whether within the social context that we're implementing them in, they will work. So the first one is relative advantage. Is the solution better than what is in existence? That's relative advantage. Is it better than what they have? Compatibility. Is it compatible with their principles, with their ethical principles, with their values? Is it compatible with their level of understanding, level of expertise, and so on? Complexity. Is it a 30-page guideline or is it a 1-page checklist? So how do we make it easy for people to do the right thing? Trialability. Can they try it out? Can we give the checklist to a surgeon today and say, use it, try it, taste it, feel it, and then tell me what you thought, and we'll immediately change it based on your comments. So trialability is about people being able to try themselves. And observability is about the capacity to see that the implementation of the new thing is actually making a tangible difference to our work, and it's making our lives easier. Next slide. This is a model for improvement. If Brandon Bennett had a session with you, you've probably seen this, and we frame every single thing that we do around this model as a way of thinking and sometimes as a way of guiding our measurement strategies. What are we trying to accomplish? What's our aim? How much by when? So are we trying to reduce surgical site infections by 50%? Are we trying to reduce the incidence of falls by 30% by December 2011? So that's the first question. The second question is around measurement of process and outcomes, so the insertion of the bundle and the outcome of infections. So how will we know that a change is an improvement? And the last one is about the specific changes within the context. So what changes do we need to do for that checklist to work, for instance? And the Plan, Do, Study, Act is just the essence of trying things out and studying what happened and acting pretty quickly and pretty dynamically. So not thinking about change as changing the world, but thinking about change as starting to eat an elephant through one bite. So how do you eat an elephant? And you have to start with one bite. So this is about learning sequentially and learning in chunks. Next slide. And the last invitation for you to consider is this idea that in every social system and with every thing that we interact with, be it technology, be it healthcare interventions, be it TV programs, there is a normal curve of people who are On one extreme, innovators. These are people that are hyper, that have loads of ideas and love to talk about them all the time. And on the other extreme, on the right-hand side, is the laggards, people that just do not, nothing's good enough for them. So no matter how sexy, how cool, how good, how simple something is, they will always have something to say. And as I say these words, you can probably picture your innovators and your laggards within your own context.